talks, conversation manner than has been done in the past. We have a really exciting talk today that I'll introduce in just a second. We just asked, for the sake of this conversation, for microphones on mute during the talk, and we will have some intermittent time points where we'll unmute people to ask some questions and get involved. And then the last thing we ask of you is to just not come too close to the screen, kind of the same etiquette you would use in a real call or a movie theater, just because it interrupts, it gets in the way of people being able to see the slides. All right, without further ado, James.
All right. Thank you, Dr. Omar. All right, so I want to, where did I go? Here we go. So I want to introduce our very special guest today, Dr. Nikhil Verma. So Dr. Verma is a double board certified physical medicine rehab physician and interventional pain management specialist. He completed his undergraduate studies in Ohio State University. He completed his internship at Wayne State University, Crittenton Branch in Rochester Hills, Michigan, followed by his residency at Kingsbrook Jewish Rehab Institute in Brooklyn, New York. He then went to a North American Spine Society recognized program, the Alabama Orthopedic Spine and Sports Program in Birmingham, Alabama. Dr. Verma, as we all know, is passionate about interventional procedures, treating musculoskeletal injuries, rehabilitation, physical therapy, ultrasound-guided procedures, preventative exercise training, and regenerative medicine. He currently practices at Essential Sports and Spine Solutions, where he utilizes evidence-based, innovative, non-surgical treatment and minimally invasive procedures to help his patients who suffer from painful and chronic injuries. His aim is to provide unique pain solutions for injuries that can cause back pain, neck pain, joint pain, nerve pain, and headaches. Dr. Verma is actively involved in his field and is a member of many professional organizations, including the American Academy of Physical Medicine and Rehab, American Society of Interventional Pain Physicians, the North American Spine Society, and the American Society of Pain and Neuroscience, just to name a few. So, all right, without further ado, I would like to welcome Dr. Nikhil Verma. Let's give him a round of applause. Dr. Verma, the stage is yours.
Thank you, guys. Thank you, James. Thank you, Dr. Omar, as well, to help set this up. Thanks, Juan, with all the work. This doesn't go without it should go with more recognition of how hard you guys work to get this all organized. I want to thank everyone to join us tonight. I know you could be doing off. I appreciate you taking this. Where this came from, this topic, I don't have the author's name in front of my head now because I have this Oculus on, but this ABCs of degenerative spine is probably one of the most essential cornerstone lectures that you should have read, interested in interventional spine, how the cascade works, and what our current beliefs are in that process. And with that, you can really understand how to treat almost all our spine injuries or back pain, et cetera, et cetera. Add in this D because, as we'll see now, this multifidi atrophy might be another aspect that we're kind of underplaying. So I'll get to that when we get there. So I'm not going to read these slides slide by slide, but I'm going to kind of put it as an overview to explain what happens in our natural degenerative cascade. So the big thing is the one thing as the functional spine, as we see here on the right, which a vertebral body, a disc, another vertebral body, inferior articular process. So, we look at this as a functional spine unit. This can move in all the axes because of this nucleus propulsus in the middle. Sorry, trying to go back. Here we go. And that's where we'll start our journey. And just remember that most of our access is on the front of the spine, or in that, the disc area. So as we see, the disc can increase that axial load pressure. And what would be nice is if it went as our body designed it to go in pretty much a perfect circle. But as we know, we don't do that because we sit too much. We might have a labor-intensive job. We might get in a car accident. We might, herniate a disc from all these other reasons. So that's just where I like to start in thinking about things. And we'll see through the cascade, what I'm talking about is we'll have A changes in the disc, B changes in the middle section, and then C changes happen in the posterior elements. So we're talking about the A changes. So the majority of cases of degenerative process start with the nucleus pulposus. So this is something that was huge in my fellowship. We injected a lot of discs with interdiscal steroid injections. Across the U.S., this isn't typically a popular treatment option for patients because back a few years ago, they were assuming that if we injected the disc, that it would increase our risk of degenerative disc disease. But if you actually go back and look at those lectures, what they actually found is those were unhealthy controls. So we don't know what happens if we're already dealing with the degenerative disc if we inject it. So this is kind of where we start, again, where I start the journey, because it is such a complex system. It's not just fluid in there. There's different types of collagen, proteoglycans, et cetera, et cetera. So, intradiscal steroids with some numbing medication might work great, but
Dr. Verma, I believe you may have
muted.
Sorry, yeah, I don't know what happened there. I kind of got just cut out there.
No
sorry about that. So, anyways, we're looking at the axial load, not only the axial load. So just to let everyone know, you'll have the ability to move these slides. I ask you not to do that. Just if you put your hand on the screen, it'll push it forward. It'll just be helpful for the interest of the talk. But as we see, we have the nucleus pulposus in the middle that has compression forces, but also the annulus fibers in the outer portion that has. And these changes happen structurally over time, and we know that because we can see degenerative spine, especially when we classify in the Fearman scores. There's structural weakness. It changes the load compression from going up and down, straight down, to now kind of having a forward and back motion. And this is pretty much irreversible because we have so many, we don't have a good vascular flow to that. So this is why I'm interested in the autologous therapies that we might have in the near future. Viadisc is one that we've been working well with a company that has some pretty good studies in their VAST studies. Excited to see where that treatment goes. And other things, out there, we do some PRP injections, we can do ozone, we can do BMAC, even lipogems into that, or fat aspiration into that. That might help the back pain and the degenerative cascade. So we'll kind of put that on a hold for now and see what else we have to talk about. So as we can see, there's different types of phenomenons that happen as a nucleus pulposus degenerates. We can get a vacuum phenomenon, you can get interdiscal fluid, and you can get severe degeneration as well, and calcifications that can cause more damage. Let's just make sure there's nothing else. So before I move to B changes, I would like, I'd like to open the floor if anyone has any specific questions or has any experience with these discs or treating discs or degenerative disc cascade.
Yeah, I always like to chime in. So, interestingly enough, prior to reading this paper, discs had always been kind of an enigma to me. I didn't really understand, what its significance was in terms of MRI changes. I didn't know what its significance was in terms of structural instability. I just figured it's probably the first thing that degenerates because it's the softest thing, in the back. But now it makes sense that, as we have disc desiccation and loss of height, that really initiates that cascade of degeneration because it's transmitting all that force, all those force vectors onto structures that otherwise don't want to bear weight or bear load.
Yeah, exactly right. And I think you're right. Even if we talk to the radiologists, they hardly comment on the disc unless it's severe. So that's something to keep in mind, especially if you're treating back pain. Okay, cool. So let's move on. So the annulus fibrosis, so those outer rings. So we can see on these forces more actively. It can cause these micro tears in the back. We call these high intensity signals on MRI, and it can also cause disc herniation and disc bulges. I'm not going to get too much into the details about those specifically here, but just to keep that for these terms, but kind of how this is usually the next step. And here are those pictures of the disc displacement. So you can have annular bulging, protrusions, extrusions, where the nucleus propulsive outlet comes out of the annulus fibers, and extrusion and sequestration. So again, not going to talk too much into this, but this is another thing to realize, because those annulus fibers, again, not commented often on MRI, and also see on our patients that they have a lot of back pain. When you see an annulus fiber tear, like, yes, that's likely where your pain is coming from. And this is where we start thinking of, oh, maybe we should start treating the disc. So these type of patients typically are younger. They have axial low back pain, non-radiating, if it's annulus fibers related. If it has herniation, then it can definitely cause radiculopathy, obviously, if it's pushing on the nerves, especially exiting out of foramen. So again, just some more examples. As you can see in the axial plane, how it looks in different areas. I do want to put on the third image on the axial cuts, you want to see this foraminal or extraforaminal. So you can see where this disc herniation is. And I don't know if I can really show this, but maybe on this model, I don't know where the DRG lands. I don't know, James, maybe you could help show them on this other model.
I got you.
And try to, get it to link up with that. Because that DRG can be super painful. I actually had a patient this week. They came in with just excruciating back pain and leg pain. And she said, described it as her leg was feeling like it was being gnawed off. And the neurosurgeon at the hospital said, this isn't anything they need to deal with. So she comes to my office with the MRI, and I see this, and I see the far lateral herniation sitting right on her DRG. We know that dorsal root ganglion is a cluster of cells that relay all our information, not just pain signals, but all of our signals up and down to the relay centers in the brain. So and it made sense because of that. She was also distraught, and it was also leading to anxiety, etc. I did epidural. It worked well, but I still think she needs surgery. So I sent her to another neurosurgeon for a second opinion. So that's why it's important to kind of learn to read your own MRIs, and that's why this particular paper is so good. So extrusion versus excavation, again, extrusion can leak out. Excavation will actually come out and surround the spine. A lot of problems. That's why it's important to start learning how to read your own MRIs. Just another example of that, really just talking about the disc overall. So you can see, again, the DRG can get pressed on pretty easily if you see how close that is. And that is the foramen. So when we look at a transforaminal, we're coming, where'd that needle go? Oops. Yeah. Perfect. If I can grab it.
You just got to walk a little bit closer to it. There you go.
I got it, yeah. So yeah, we're doing our transforaminals right here. Yeah, if you can help me put it where I need to put it. So, we're coming here or underneath. It depends on which angle you're coming in at. And you can see from that last image of how close those disc herniations can be to that foramen, because this is the foramen right where that arrow is pointing down. So just keep that in mind as well. All right. So next thing we talk about is the end plate changes. So this is, interesting because, again, we would see these end plate changes, smoral nodes, or even modic changes, and we didn't know what to do with them in the past. So the way I think about this now is, when I see these end plate changes, I know that this disc is not actually separated from the end plates. It's actually contiguous. And in a way that there's kind of end plates and gap junctions that help communicate and send some materials to one another. But again, it's not a very vascular area. So when there's end plate changes, this could be another sign of degenerative changes of the spine in this B section, the B changes of the disc. Again, this can be very painful. I think this is where our intradiscal treatments can start evolving to help treat things. And then this is also where, if you guys have heard of the Relievant Intercept procedure, not with this specifically, but with the modic changes, then, those are actually candidates that will get the basovertebral nerve ablation and can help this chronic axial low back pain patient population. Again, modic changes were almost never talked about from the radiologist, but now as we're getting more treatment options or we're learning to treat the spine better, you'll start noticing that more on our MRI reports. And so again, this is the bone marrow. So we have the modic type 1, type 2, and type 3. Again, it's not going to harp on the definitions. You can visualize it, and we can get into it more in detail if anyone has questions about it. And I want to show you here, as we see modic 1, 2, and 3 across the board. So 1 is typically just inflammatory changes, blood vessels, and some angiogenesis, and then finally turns into fatty bone marrow changes. And that's kind of how the degenerative spine cascade works as well. And we kind of see that. What's interesting about these images that we have, MRIs, that we don't see any slippage or listhesis. And we'll talk why I find that interesting in a little bit when we get to the C changes. So again, here's just a little bit more about the cascade, but we have degenerative intervertebral instability. And again, that's where we start seeing a spondylolisthesis. And when the spondylolisthesis, the slippage of our vertebral body on top of one another, can start causing back pain in itself. And in result for that, because now we have a structurally unstable segment, there's going to be a compensatory mechanisms of the body to react to this. So what happens is our facet joints start to get these hypertrophic changes, but also the end plates get hypertrophic changes. So you might see some osteophytes on the end plates because of the body's trying to protect itself, lock to that segment. So I want to pause there at the B segment. So we're really talking about the disc and the disc changes. Does anyone have any questions or comments at that section?
Quick question for you, Dr. Verma. This is Dr. Omar here. So, it was interestingly enough, you brought up the fact that modic changes not too long ago were, we were kind of just taught that they were these radiological findings, and for the most part, many of us just dismissed them not having any sort of clinical correlation. How have you now sort of changed your approach to, reading your own MRI? Do you always look for modic changes now? How do you do it? Can you?
Yes. So that's actually a great question. We got our hands on our patients and do a physical exam. If they have a radicular symptom, I'm probably going to treat the radiculopathy first. I'm going to look at the other changes of the spine. But yeah, to your point is when I see that MRI, if I see motor changes and they say it's axial low back pain, 20%, if not up to 70% of their pain is coming from the vertebrogenic or discogenic. A lot of people say they can tell you the difference. I can't. The only way I know to tell the difference is if I try a procedure and it works. That's the only way I could tell the difference between the two.
Right.
People will say the sustained hip flexion test exam is good for discogenic pain, where you'll have the patient lay on their back, raise their legs to 30 degrees, 40 degrees, and then have them apply a slight downward pressure on your supported arms. And if that exacerbates their pain, it's more likely discogenic. But again, I don't know what I'm treating. So in the interest of how long the basovertebral nerve ablation lasts, or not lasts, how long it takes to do the procedure versus an intradiscal procedure, right, I'd much likely go towards an intradiscal treatment just because it's quicker. And it might help. Right. So I hope I answered your question.
You did. Thank you.
So yeah, okay. So we'll move on to the facet joints. And as I was talking on this last slide, is when we get the spondylosis because of the degenerative cascade and instability, spondylolisthesis, our bodies try to overcompensate, and we cause this facet joint arthropathy. And we can see here on a patient that would be lying on their back, the facet joints are super red because it's trying to lock in that segment so it doesn't translate forward and backwards. So keep that in mind. We'll talk a little bit more about that, but we can see different examples of facet joint degeneration. We have here a little bit more severe, almost completely spondylitic. And here we actually see severe narrowing of the foramen and potentially the inner canal space too, because of how much degradation happens. So when that segment starts moving forward to backwards, our bodies, just like any other ligament, is going to start hyperproliferating, or at least that's what we think goes on with this ligamentum flavum. I've also heard it described as the ligament actually buckling, meaning it's being redundant and overturning itself. So let's get this one to do an axial too. So that the ligament would be that white structure on top up there. And you can see if that's going to get thickened, it's going to cause a compression, a little bit of a pinching. So we have some other great products, these sort of inner-spinous spacer devices that are coming more and more popular. Vertiflex is great. Minuteman is another one. We have iSpine. There's a handful of Aurora Zip. There's a handful of them out there. And I think the data is too early on a lot of them to tell what we're going to do. But for the right patient, for the right treatment, it might be the best thing. Let's see. Okay. So I'm lagging, sorry. Get back to it. As we know, that changes too. This is where we focus on we'll go back to facet joint changes. This is where we focus on medial branch blocks and our radial frequency ablations, because what we're doing is that may be causing the back pain. But if you just think about that, is if we're just treating the posterior elements and we're not treating the anterior elements, are we actually taking care of all the pain? So that's another thing, way I think about things overall. Just because insurance says we can only treat one thing at a time, but we may not be healing or helping our patient 100%. All the destruction of the facet joints, that's why sometimes I feel like the radiofrequency ablation may be more destructive, because, hold that thought, I'll talk to you about it when we get to point D, D changes. We talked about the ligamentum flavum. Also, we have the mild procedure, which is coming a more popular procedure, where we'll go in and debunk the ligamentum flavum and help give some space in that area. As my fellowship director always told us is, if your shoe's too tight, you don't just inject your foot, but you just take off your shoe, so you got to loosen up what's tight in there. And that's kind of how I describe to my patients when we have the right patient. Here's some examples of the cervical spine. Cervical spine can be a little bit more tricky because the motion in the cervical spine are differ from the lumbar spine. But you just want to keep in mind, similar things can happen, joint arthropathies and pinching of the nerves outside the frame. That's why I start with the Laminator epidural steroid injection. Before I do this, then the transforaminal can be, the foramen kind of looks like a cone. So it's wider on the outside, narrow, and widens on the inside. So you don't always get the best view when you're looking at an X-ray. You really need a CT to help you guide. That's why. But again, we can talk about the lumbar spine a little bit more confidently, because we see it a lot more. With the facet changes, we'll actually get some fluid in the facet joints. So this fluid is hypertrophy of the synovial fluid, where we're trying to stabilize that segment because it's unsturdy, as we talked about, because that's degenerative disc disease leading to instability, leading to listhesis, leading to spondylosis. And the more aggressive it happens, the more arthropathy you get in the facet. You can get some pretty severe facet arthropathy that can even cause facet fluid, that can even cause clonoquidin syndrome, because it's so tight in that area. Some other changes that we can see, these are more the superior in the cervical spine, the AA joint, AO joint, et cetera, et cetera. And the only other thing, I don't know, I thought they had a slide put on here, I must have forgot, but in these facet joints, and especially in the lumbar spine, it can happen in the cervical spine too, is these facet joints can actually, these cysts can press right on the spinal canal in the middle. They can sit in the foramen, or they can be up and down in the spine, outside the spinal cord itself, but in the, where the nerve rootlets are going down, like especially in the lateral recess. So oftentimes, if I see that in a patient, we'll go and try to rupture the cyst and hope to take care of their symptoms. And it's not always successful, but once they get that pressure, it feels so much better. So, all right. So the last portion, this is what I kind of muscles are erector muscles of the lumbar spine. They help keep us stable. And when you look at this on the MRI, we start seeing more and more atrophy. And there's a few physical therapists out there that really believe that this is either the cause of back pain at the start, because we have a poor physical connection, neuromuscular connection to the multifidi, because we don't know how to activate it. So when that starts degenerating, that causes the continuation of the degenerative cascade of the spine. And we can see here where we already have some degeneration of the facet joints, but we see the multifidi atrophy, mild, moderate, and severe. And, we usually say less than 30%, 30 to 50%, over 50%. And we can see this is in the lumbar sacral spine because we can see our SI joints coming in. So towards the L5, bottom of the L5. And again, this is where the multifidi muscles and the erecti spinae live. So what's interesting about this is they found individuals with impaired lumbopelvic control demonstrated the activation was deficit. So to do this, we check a prone instability test. Hard to show here, but you look that up and, add this into your repertoire, because if you have a patient with mechanical axial low back pain, this is typically our patients that are about 45 to 60 that are still active, and they just have this chronic nagging low back pain. Check the prone instability test. Check their MRI. See if they have multifidi atrophy, ablative space. So if we think back to what I was talking about, innervating the facet joints, then what we're actually also doing is those medial branches and the dorsal rami actually also innervate the multifidi muscles. And we know this because this is why we do EMGs, and when we're testing for radiculopathy, we needle the paraspinal muscles for this reason. So if we're actually destroying this in these radiofrequency ablations, are we causing more damage? This is what I've been harping since residency, and I get all types of answers. Some studies are very suggestive that we are doing more damage, but at a certain age, are we doing the right thing for the patient? So I can definitely agree with that. But if like a 23-year-old comes into my office and has this mechanical axial low back pain, do I really want to burn these nerves and potentiate a future problem? This is something I really harp on my patients that are 50 or below. Like, we should really consider regenerative medicine, whether that be PRP or bone marrow or something. Or alternatively, some of the authors of these studies have been working with Reactivate, Mainstay Medical, who has a Reactivate therapy where you put some motor stimulation on the L3 medial branches, and you actually stimulate that for 20 minutes a day, pretty much lifelong. And that actually is shown to help decrease axial low back pain. So that's why I'm pretty excited about this therapy. I think we're still in the very beginning stages of it, but I'm excited to see where it goes. So that's about all I have to talk about. Like to open up the floor to discussion, questions, and et cetera, et cetera.
Awesome. Thank you so much, Dr. Verma. That was outstanding conversation. I'm just going to start unmuting some people here. If you have a question, why don't you maybe raise your hand? Kind of start getting some in there.
I can get it started. So,
Yeah.
When you have a patient in your clinic and, you do a physical exam, you look at imaging, and then you kind of put a nail on what you think might be the primary pain generator in this case, to what extent do you go through to explain to that patient, are you using models? Do you, take them through the whole cascade? Do you kind of focus in on what you think is contributing, or what's your approach basically?
Yeah, that's a great question. So I think the first thing is, you do the physical exam, you ask the questions. What were you doing when this happened? You take into consideration, what do they do for a living? If they're a manual laborer, etc. Anyway, so I'll look at the MRI and I'll look right at the disc first. I usually look right at the disc in the spinal canal. Let's see if we can get one of the MRIs up that has if we can flip through. But yeah, so I'll look at the spinal canal on a sagittal view and an axial view, just to see if there's any spinal canal stenosis, because then, or a herniated disc. That's what I'm looking first. That's a good one. Yeah, right there.
There we go.
Yep, perfect. So yeah, I'm looking at the spinal canal first, making sure that there's no severe pinching of the spinal canal stenosis. Then I look at the discs next, and obviously one of these discs we show different levels of degeneration. Then I look for a listhesis, and then I'll go to my axial views. Actually, we have an axial view right there, so on the back.
Oh, there we go.
Yeah, I'll look at my axial views to see if there's any facet arthropathies, facet fluid. So I think about it systemically. If they have radicular symptoms, obviously when they're coming to me, they've usually failed physical therapy and conservative measures otherwise. So that's why they're coming to us. So then I'm usually more likely to do an epidural steroid injection. So the epidural that I usually like to do depends. If they have more back pain, then I'm going to do a interlaminar injection, or maybe a caudal. If they have more herniated disc that's sitting on a nerve coming out the foramen, I usually look at that and I'll decide if I'm going to do a 1-level, 2-level transforaminal steroid injection.
Dr. Verma, would you, for those of us in the audience who might not be too familiar with the terminology behind some of the technical aspects, would you be able to kind of demonstrate on one of these models here, the difference between an interlaminar versus transforaminal versus intradiscal injection?
Yeah, just give me 1 second. Actually, the low battery came up.
Okay.
The low battery came up on my headset, so.
Oh yeah,
That's okay. You should probably have a couple more.
sometimes my low battery sign comes on in real life.
Yeah.
I have
Yeah.
to
So.
go find a coffee or a Celsius Energy or something.
All right, so let's see. All right, let me get this together.
Here you go.
So, let me get this. Overshot it. So, if I can grab. So the interlaminar space here wants to grab. There we go.
Yeah, if you reach out to it and grasp it with all 3 fingers, you'll be able to manipulate it on multiple axes. Oh, I think you muted again. Dr. Verma, you there?
His headset might have died.
Okay. Oh, he's back. All right.
I'm back. So hopefully you guys started some of that demonstration, but
Here, I'll bring
We
the
can
needle
find
back here if you want to show. Here you
perfect.
go.
Yeah.
So I'm gonna hand this over to you. Okay. Here we
Okay.
go. You want to walk towards me and take that? There you go.
All right. Yeah, Mo, can you turn it just slightly towards me, the spine
Yeah,
model?
sure.
And I can just kind of. So yeah, so our interlaminar space is going to come right through here, the posterior aspect, usually at a down to up angle, just like so. Hopefully you guys can see that okay. Let's see if we can move this on this side. So that's, one approach. The next approach will be more of a transforaminal, and for the transforaminal will come, again, we can come different ways with this, and there's different approaches. Sometimes we'll come retrodiscal, meaning right behind the disc. Pull this closer. We can do it supraneural, right below the pedicle here, which is usually my preferred approach. And sometimes we come infraneural. And this really depends on where your herniation is or what is causing the problems. If the herniation is far lateral and press is in this foramen, coming to the inferior portion might not help you out. Actually, what happened today, I had a patient and I did a transforaminal, and none of the transforaminal or contrast spread through that foramen. It actually went the foramen below and came through, which I found fascinating because that patient had such severe stenosis in this foraminal space. So I found it interesting, but the contrast spread beautifully, so I said it was good enough, and I took it. So then the intradiscal approach, it's similar setup to the transforaminal, but we're coming below this nerve and into the intradiscal space. And usually what we're doing, we're coming about posterior to anterior, lateral to medial, and then we check both an anterior, an AP and a lateral image to make sure that we're in the middle of the disc space. And then finally, the facet joints and the medial branch blocks. So, in the past, we did a lot of facet injections, but the insurance companies decided that they wanted to use different criteria for medial branch blocks. So when we burn the medial branches, they actually live, and this is going to be the toughest one to show because actually, let's do this.
Yeah, if you grab the model with one hand,
Yeah.
you can manipulate it on all three axes however you'd like.
Yeah. I think it's fine though, because what I can do is just show. Yeah. It lives, there we go, on this upper aspect of the facet joint here. And the more that we can get longer on the nerve, especially with our radio frequency burns, the better our outcomes are, or at least that's what my experience has been. I don't know if James and Mo, if you guys have the same experience, or everyone out there. I try to hug as much of that little sulcus in that interforaminal or inner transverse space as I can.
I found it challenging at first. Because one of the first ways I was trained on this was doing just a direct AP approach. And that was definitely challenging until I rotated with, another one of our mentors, and he showed me that kind of that oblique approach where you get the Scotty dog and you aim right towards that pedicle. And then you, at the very last second, once you touch os, you kind of curve the bend of the needle down to hug that McBurton's point. And I started getting amazing results after that.
Yeah, it's great. And it's just, again, I don't want to, it is a great therapy for the right patient. I think too many pain doctors overdo it. And I think that's a big problem because the reimbursement was so good. And it is still good, but I don't feel like we should just do things for reimbursement. We should do it to help the patients.
Agreed.
I totally agree.
This is hence why I went into private practice, everyone. If you want to hear more of my thoughts about that, we can discuss later.
Can you go over some of the, regenerative or destructive or ablative procedures that you do? I mean, I know that obviously ablations, we're destroying these nerves with whichever theorized, degeneration patterns we inherit afterwards. But also even corticosteroids, which is like the mainstay of pain management, even that, we don't really think about how that advances degeneration. So what other options do you use in your practice?
Yeah, I always tell my patients that, these steroids are just a Band-Aid. They could potentially make things worse. The more often you get them, the worse for you, which is the truth. But it helps for acute pain. So that's why I use it for acute pain. I don't like to do it for chronic pain, but, that's unfortunately some of the patient population. So and it's great that we have these spinal units here because I treat the whole spinal unit. What we would do is, I follow the Interventional Orthobiologics Foundation's criteria of how they treat it. I went to their courses and got trained in BMAC and PRP for interventional spine procedures. So what I would do is I would treat the whole spinal unit, meaning I would treat the facet joint with PRP. I would treat the nerves with plasma lysate. Yep, and maybe a little bit of dextrose because that helps decrease nerve irritation. I would treat the disc with PRP, or if the patient wants bone marrow, then I would do bone marrow. Bone marrow tends to have better outcomes, but it's just more cost, more invasive. And And then I would also treat the ligaments, especially if there's a spondylolisthesis. We'll do some prolotherapy in the intertransverse ligaments or in the sacroiliac ligaments, because those can also help stabilize those ligaments that become lax over time. Similarly, if there's a pars fracture, I would treat that with bone marrow or PRP.
Amazing. Now, are you identifying these structures, these soft tissue structures, are you using ultrasound or fluoro or a combination of both?
I'm just so much more comfortable with fluoroscopy for the spine that I tend to lean on that heavily. If you wanted to, and you weren't going to mess with the disc or the inner epidural space, and you want to treat the multifidi, you could treat the multifidi with some PPP, platelet poor plasma, just straight up inject those, and that might help a little bit there. And you can also inject with plasma lysate, so that might help with some of the atrophy there. So under ultrasound, you can identify all these things. You can identify the multifidi, you can identify the facet joints pretty easily, you can identify the interspinous ligament pretty easily. So I would just kind of treat all those segments. And then SI joint is another huge pathology where I feel like we're over-treating with steroids and ablative, or maybe even these fusion devices where we should just start with prolotherapy, something as simple as that.
I totally agree with you on that front. Yeah. Could you walk us through kind of like that distraction technique that they use for these posterior approach fusions?
So I've used corner lock, and I guess we don't have a sacro model, but that's okay. So where to go? Sorry. Yeah, so I've done corner lock case, and what you do, you'll have the patient kind of in a flex position, and you find the superior aspect of the SI joint and then the inferior aspect of the SI joint. And for their device particularly, you drill a small little hole into each, and then you kind of slam in the bone marrow matrix. So I don't necessarily believe that this is a true fusion. If you think of true fusion, we're like actually bridging the whole joint, or at least majority of the joint. Right. We're really just putting in two small little things. And the way I think about this is we're actually putting a wedge in like underneath a rickety table. You're just putting a distraction device so it's not so rickety, and that's going to decrease their pain. With this being said, my cases that I've done, they do so well, but I'm very hesitant to pick my patients and to do them.
I totally agree. I think, in my experience, those posterior approach techniques are great for the older individual who you might not be they've had chronic effect from steroids, and they might not give you the best either platelet or bone marrow aspirate yields, and obviously surgery wouldn't be an option, and so this buys time. I guess my issue with those techniques is by placing distraction in that joint, you're reestablishing that on ligaments that are otherwise still pathological. And so down the road, I would expect to see, degeneration of that joint again. But we'll see. Only time will tell.
Yeah, no, I agree.
Yeah. I think that the key is really trying to hone in on whether or not the pain from the SI joint is coming from micromotion of the joint. Yeah. And it's very difficult to do. Yeah.
Yeah. So I know we have a couple pain physicians amongst us. Does anybody else have questions? Want to unmute themselves and chime in? In the meantime, I'm going to place this needle in the disc, like so.
And if there's anyone out there, please feel free to reach out to me on social media. I'm usually pretty responsive. I talk a lot about
a YouTube channel.
Yeah, this is all about that. I have a YouTube channel, things I didn't learn in med school, where I pretty much I walk through what my experience has been of open private practice and some of the pitfalls and some other things that I didn't realize in med school or residency, or I just chose to actively ignore because I was too busy studying anatomy. It's been a pretty fun project and it's growing. I have some obviously videos that are more pertinent than others, but hopefully if you guys enjoy that kind of stuff, it's up on YouTube and get it to a podcast format sometime soon.
Awesome. Well, thanks so much, Dr. Verma. I mean, honestly, this was a fantastic talk. We learned a ton.
Well, I appreciate you guys setting this up, and it was a lot of fun, and hopefully we'll do something else in the
Oh,
next year.
absolutely. We'd love to have you back, and I'm sure everyone in the audience agrees. Guys, we're gonna leave some of these models on stage for people to be able to run with, use, kind of go over kind of some of the things that Dr. Verma talked about up close and personal. I'll even duplicate a few of them.
But before we
people
go,
to
we
be
got to
able to
take a
use.
selfie.
That's right. We got to do our selfie.
Everyone get up on the stage.
All right. So everybody
Turn
that's up
around.
here, why don't you go ahead,
Everyone turn around.
turn around and say cheese. Look towards the back of the stage. There we go. All right, on 3. 1, 2, 3. Boom. Beautiful.
All right.
What a beautiful group of gorgeous people.
Good times. All right, everyone, have a good night.
Thank
All
you.
right, everyone. Follow us, guys, on Instagram, Twitter, and TikTok. We're here every Thursday at 7 p.m. You'll find our links for registration. It's always free for you guys. And we'll see you next week.